Good afternoon, everyone. My name is Chelsea Lynch from NQF. Thank you for joining us. Please review the housekeeping reminders and we'll get started in just a minute. Okay, Evelyn, if you could advance to the next slide, please. Hello again, everyone. Welcome to our sixth and final web meeting of the Leveraging EHR Source Measures to Improve Care Communication and Coordination option year. My name is Chelsea Lynch, and I'm a Director in Emerging Initiatives at the National Quality Forum. We truly appreciate that all of you have joined us today and that you're prioritizing this work within your busy schedules. Additionally, we'd like to thank CMS for funding this important work. I'm really looking forward to our meeting today as we review public comments and committee feedback to identify modifications to the two final recommendations reports, as well as discuss future steps for this work. I know we're all familiar with these meeting platforms, but it's always good to share a few housekeeping reminders before we get started. We're on the WebEx platform today, which has audio and video capabilities. Please note we will not be using breakout groups today. Also, please place yourself on mute when you're not speaking, and we encourage you to keep your video on, especially when you are speaking. As always, please feel free to use the chat box to communicate with NQF staff and with each other, and please use the raise hand feature during discussion to be called upon to speak. We'll take committee attendance shortly. And as we move on to the next slide, I'd like to invite our co-chairs, Dr. Richard Antonelli and Dr. Jerry Lamb, to share any additional welcoming remarks. Jerry, could we start with you today?
I would be delighted to. Hi, everybody. Glad to be with you. I cannot believe this is our very last meeting. And if we don't have a chance to say it at the end, I would just like to say how much I appreciate the whole committee, every one of you, participating so actively and so meaningfully in these reports. I'm hoping that everybody feels really proud and very productive with these reports. I also want to acknowledge tremendous work on the part of NQF staff and our CMS colleagues, ONC colleagues. This has been just an incredible experience, and I want to thank you all, and I'm looking forward to the feedback today. Rich?
Thanks, Jerry. And I also want to take a moment to just reflect with deep gratitude the tremendous contributions of this diverse committee. On the one hand, today is the final session, but I don't view the work as ending. It's actually, for me, it's a beginning. And then what are we going to do about this? And this is the collective we. So if you haven't had a chance to look at the agenda, you'll see that we've devoted a fair amount of time after we review the public comments to say, so what is next? I don't think any of us feels like, okay, this is good, it's going to stand on its own. Our committee's work is over. I'm incredibly proud of what we've done. Jerry, you've been an amazing co-chair. Thank you. Chelsea and NQF team, I've learned so much and I'm so grateful. And again, our partners in particular with CMS and the ONC, thank you so much for giving us this opportunity. And I look forward to the work today.
Great. Thank you both. On the next slide, I'll briefly go over our agenda. So after covering our objectives for today's meeting and taking attendance, we'll provide a brief overview of the final recommendations reports before we start our discussions on public comments, committee feedback, and any potential modifications to the two final recommendations reports. We'll then, as Rich mentioned, we'll transition to a discussion of future steps for this work. We'll then, as always, have a few minutes for NQF member and public comments, and we'll wrap up with next steps. On the next slide, we will get started with an overview of the meeting objectives and attendance. On the next slide, The slide should look pretty familiar. We've certainly moved that yellow square along this timeline. So we had a total of 6 web meetings, and the focus of the first 5 was to develop and refine our recommendations. Since our last meeting, we posted both final recommendations reports for public comment and also provided the committee with another opportunity to provide feedback. Today is our 6th meeting, which we'll use to consider the public comments and committee feedback we received, so we're able to finalize the reports, and then the reports will be posted in September. On the next slide, the objectives for today's meeting are to review and discuss the public comments, committee feedback, and any related modifications to the final recommendations report. And then we'll review and discuss future steps and conclude the project. And I'm going to hand it over now to Udara to take attendance. Udara?
Thanks so much, Chelsea. I'll now go through our committee roster. Please let me know if you're present as I read your name. Richard Antonelli.
Present.
Jerry Lamb.
Here.
Kathleen Balistracci.
Here.
David Buranek.
Here.
Brian Buys.
Here.
Sherry Costa. Cynthia Cullen.
Here.
Keith Horvath. Joseph Kunish.
Present.
Russell Leftwich. Michael Lieberman.
Present.
Brent Peary. I did see a chat earlier saying that he was unable to join via audio. Rebecca Perez.
Present.
Ann Polish. Walter Rosenberg. Stacy Schilling. Sue Ellen Shea.
Present.
Colleen Scow.
Present.
Alexis Snyder.
Good afternoon.
Maureen Stewart. Jason Weisner. Dorothy Winningham.
Here.
Kim Yu. Andrew Zinkel.
Present. Sorry, was late unmuting.
Great, thank you both. Is there anyone that I may have missed that may have come in after their name was called? Okay,
Sherry.
and moving on. Sorry, did I hear someone?
Is Brent in? Can we confirm that his name just appeared on my chat list? Brent, are you hearing us?
Hello, Sherry Costa joined.
Thank you, Sherry. We'll keep working with Brent if he's able to join back on. Moving on to our federal liaisons, we have Joel Andress, Kyle Cobb, Chris Stymick, Tara McMullen.
Hello, I'm present.
Great, thank you. Carly Madosh, Francine Sandro, Kenneth Yale. Is there anyone that I may have missed from our federal liaisons? Okay. I'd also like to acknowledge our great team of NQF project staff. Thank you so much to Chelsea for leading this project, and to Monica, Debbie, and Jesse for all of your hard work and support. I'd additionally like to thank Chuck, Carol, Maura, and Evelyn for their support, and the IT team at NQF for their help with facilitating and running today's meeting. We'd also like to acknowledge and thank Kim Rawlings and Jaquencia Polk for their support and collaboration on this project. Before we get started, I'll quickly go over some ground rules for our meeting today. As you know, we want to emphasize that there's no rank in this room. Everyone's opinion and insight is valuable. This is a really complex topic, so your experiences are critical to the advancement of our work. Please share your experiences and learn from one another. Be respectful to other committee members and create space for different perspectives. Additionally, please refrain from making any political jokes or comments. I'd now like to hand it over to Chelsea to provide an overview of the final recommendations reports.
Thank you so much, Udara. Before we get started on our discussions, I wanted to provide yet another brief overview of our final recommendations report to provide context for our discussions today. It should all sound pretty familiar, but just wanted to make sure everyone remembered what these reports are all about. So on the next slide. So this is the remaining timeline for the development of the reports. As we've mentioned a couple times, we're discussing public comments, committee feedback, and potential modifications to the report during today's meeting. The NQF team will then make the final updates to the reports with another round of drafts shared with CMS before the final reports are submitted to CMS on September 14th. And then the reports will be posted on the NQF website on September 19th. On the next slide, we provide an overview of the first report, which is the final recommendations report. This is pretty typical of an NQF report. It's more technical, it's pretty detailed, really showcasing the committee's recommendations for a more technical audience of measure developers, EHR vendors, healthcare providers, and other quality measurement stakeholders. On the next slide, we have the shortened final recommendations report. So this report is less technical, the intent to be visually appealing with an engaging tone that highlights the committee's recommendations, but the audience is for change makers, policy and legislative professionals, and other healthcare executives. And really the intent here is to educate the broad audience of individuals about the importance of this topic area and our recommendations. So just a reminder that there are these two reports, but the content is the same, just presented a little bit differently. So our conversations that we have here, there should be a lot of crossover between the two reports. So on the next slide, we'll start our transition to discussing the public comments, committee feedback, and potential modifications needed to finalize the reports. On the next slide, we will start with the public comments. So both reports were posted for a 21-day review and public commenting period on July 1st. 5 prompts were used to elicit feedback from the public. These prompts included obtaining general feedback on both reports, as well as feedback on the recommendations related to effectively facilitating care communication and care coordination with EHRs, and to leveraging EHR source measures to improve care communication and care coordination, and the additional considerations for advancing EHR source measurement. On the next slide, so we received 15 public comments from 5 individuals, and they were from 2 identified organizations, and 3 commenters did not have an organization that they identified. So on the next slide, I'll briefly go over the themes from the public comments we received, and then we'll get into the different discussion questions. A commenter wanted to express the importance of patient portals and patient communication, suggesting additional language to be added to highlight this more. There are also a couple of comments about the lack of data sharing requirements with health insurance providers, which are an important stakeholder for improving healthcare quality and equity. There were also comments related to the importance of having incentives to really advance the recommendations. Another commenter suggested additional emphasis for data capture from non-EHR digital devices and for standardizing patient-reported outcomes and functional status measures. And a couple commenters also shared some other initiatives relevant to this work: the CDC's Adapting Clinical Guidelines for the Digital Age and ONC's Trusted Exchange Framework and Common Agreement, which we'll provide a little bit more detail on in a future slide. So please note that we're not intending to discuss all the public comments we received. Rather, we'll focus on comments we think need additional discussion to finalize the reports. However, if there's a comment that we don't get into detail about that you think it's important for us to discuss, please let us know at a later slide. So on the next slide, we will get into our first discussion question, which is: what considerations, if any, does the committee want to include regarding the lack of data sharing requirements for health insurance providers and interoperability incentives? So another way to look at that is anybody opposed to health insurance providers having access to EHR data, or no concerns, but there are some things to look at. And I see Joseph with his hand up.
Hi. I think from my perspective, and I think this was alluded to when the promoting interoperability rule came out, the intent, CMS is really to put the control of the personal health information to the patient. And that would allow them then to filter out what they want to share with whatever, company, insurance, being an insurance or other providers. And that's kind of in the healthcare on the provider side, you can't just share a patient's full chart somewhere without them giving you that permission to do that. And I think that was the intent, which I can see from the insurance perspective, and they made some valid points on, being able to identify gaps, also social determinants of health. But I think, by endorsing the ability to freely share that information without that patient having that control, there would be kind of a backlash from the public to say, well, no, there might be some, psychiatric information in there I don't want shared. There's still a lot of rules around that. But, even your medication list, there might be medications on there that indicate certain things you don't want shared with either another insurance provider or another provider in general. So I again, going back to, I think that was the intent of having the insurance companies have to share that information with a third party application that then that patient had control over, and then they could determine it from there. That's all.
I see a comment from Alexis agreeing with that as well. And Alexis, go ahead.
Yeah, I guess I somewhat have more of a comment or question, I guess, at this point, instead of a comment, because I'm just rereading the question again, and I'm not sure, was the concern from this person who made a public comment the concern that health insurance companies should have full access, or are they concerned over the lack of requirements for the insurers to provide information to the patients as requested? Because that's very different.
Yes, I believe it was wanting health insurance providers to have access to data.
Okay, so then I still agree with those comments. Yeah, I think that there's no way that they should be allowed to have an all access hands-on chart information. They should be on a need to know basis, for billing and for prior authorizations, etc.
I see Sue Ellen sharing that there's a way to de-identify patient information so the data can be shared. If it's more for quality improvement. Just a thought there. And Jerry, I see your hand raised.
I was looking at the proposed committee response, and what I appreciate, first off, I agree with Joseph. There are some parameters that need to be considered in making data available. But I like the way that in the committee response, it identifies health insurance providers as critical stakeholders. And I guess what I would be comfortable with is, if we haven't done it to everybody's satisfaction, is to recognize that there are a lot of stakeholders in this process, and that we have put patients and families in the center of it, but that we need to consider their needs and the ability to get the data to where it needs to be. I think in general, though, I agree with Joseph. We need to look at the roles of different stakeholders and what's appropriate for them and what kind of guidelines we need to follow. But I don't have any problem in identifying insurance providers as critical stakeholders.
I think also there's a part of this where, is it possible that they may have information that they're not sharing with the physicians and therefore the physicians are not able to share with their patients? So the interoperability part of the comment from the AHIP person in this particular discussion, public comment, really spoke to more just advancing policies that look at interoperability. And I would support that. I mean, I see a lot of issues with not just health insurers, but hospital systems and others where data gets held hostage, and unless the practice pays for access to certain things, they're not able to get some of the data that they want to be able to get, right? And so not having integrated operability and robust HIE systems throughout the country makes it really difficult. And we should do everything that we can do to be able to foster interoperability so that we can take care of our patients better.
Thank you, Kim. And I also see a comment from Dave in the chat that as long as plans are using it for health insurance, gaps in care, administrative purposes, then it would be good to allow access. And it seems like Sue Ellen agrees with the interoperability aspect of the data as well. So it sounds like to me that we agree that there are lots of different stakeholders that may need to have access to data, but it would still need to keep the patients and family at the center with the understanding that they have control over their data, but potentially still understanding there could be need for that interoperable data just for information sharing. Does that seem like a decent summary? Any other thoughts or anything anyone would like to add?
Chelsea, I think, so I would agree, maybe a friendly amendment to the summary that you just gave is, this is Rich Antonelli for those of you that might not be having video. To the extent that those stakeholders can contribute to the outcomes that we're looking for. So I'm tracking the chat and listening to the verbiage. And so to the extent that the insurers play a critical role, for example, in prior auths and care transitions was one of the things that our AHIP commented, which I think is absolutely essential. So I think rather than coming up with a specific set of criteria, the recognition, this is going to riff off of what Jerry had said, multiple stakeholders are relevant to equitable outcomes for coordination of care and communication. Defining what those roles would be should actually be part of the quid pro quo for giving access there. And I think that's one way to ensure everybody gets the data that they need, but the data has to flow in multiple directions if it's really a system designed to improve equitable patient and family-centered outcomes.
Thanks, Rich. And I think Brian's agreeing with that to the extent that payer is participating in care coordination and collaboration, they're a critical stakeholder who needs access to data. If it's claims payment, then it's slightly different. So it sounds like we're kind of in agreement there. Any other? And it seems like Rebecca is agreeing with you as well. Any other final thoughts or comments related to this question? Okay, then I think we can go on to The next discussion question, which I think should be pretty interesting. We've certainly talked a little bit about incentives already, but certainly there could be more we could add. So are there any considerations or any additions the committee wants to include regarding incentives to advance the recommendations? Right now, we need incentives. So if there's any additional thoughts or ideas about what those incentives could look like, again, also remembering that there are so many stakeholders at the table for this.
When you look at, in general, the number of hours that a practice has to submit quality measures, it comes to several hours every day. They've done research. AAFP has actually done a research study on this, and so you're talking about if we're adding measures that are EHR based, we're going to have people that put the data into the EHR, but also ensure that we have the people that will able to look at the data afterwards, that we're doing the right thing. So especially if it's not helped by an ACO or by a payer. So I would consider that they would need to be able to have enough funding to at least cover several hours a day. And depending how big the practice is, that might even be even more. So, and I can provide that resource.
Okay. And Sue Ellen has her hand raised as well.
So that comes down to Kim's point, that comes down to providing incentives, if you will, to EHR companies. And providing directives as to what is needed to reduce the burden on those who are required to collect and submit this information. Because they too should be considered a stakeholder. If we're leveraging the electronic health record, then
Any other thoughts or ideas for kind of what these incentives could look like? Jerry.
This is going to be more thinking out loud with everybody. and listening to Sue Ellen and to Kim, reality is that incentives are important. And I think the comment was made that we're working with many different stakeholders where the incentives are going to be unique to different stakeholder groups. So to acknowledge that incentives need to be there, to me is kind of, it's not, a huge aha. How they happen and the fact that there are different incentives currently in place, okay, whether it's pay for performance or it is the work that ONC is doing on the regulatory front, is should we be thinking about making a recommendation or a comment that we need to be looking at what are the incentives that are going to drive the system. I think it was Brian who said, as long as it's improving care coordination and care communication, and that's the focus, and to evaluate if the current incentives are really effective or not. So I guess my thought here is yes, incentives have to be there. That's just reality, but what we say about incentives may be important.
Thank you, Jerry. Any other thoughts? Yeah, go ahead, Rich.
Kim, I want to speak to Kim's comment because it actually relates to a lot of the research that I do measuring what care coordination looks like in practices. But I want to call something out. My hope is that if you look deeply at many of the recommendations coming out of these two reports, is that we would like to be able to move the system so that the functions of care coordination and care communication become more electronic, and that will hopefully align with increasing emphasis on EHR source performance measures, which is not explicitly part of our committee's work. We're focusing on communication and coordination. But my hope is that, in fact, the burden on practices to enter data that then feeds into quality measures that then align with a contract, either for a pay for performance or a pay for reporting, that overall the burden over time should actually be reduced so that clinicians can actually do what they're trained to do, which is to provide care. That said, Kim, not only am I not going to dismiss what you said, I want to very realistically call out the fact the system writ large is not there yet. And so on this journey toward interoperability, where EHRs are designed for communication and coordination of care, that in fact there is a sensibility that is being considered for, well, what is the additional burden to gather that data? So that's, I just want to sort of call that out. But for me, 5 or 10 years from now, success is we don't have to have people entering manual data. They should be taking care of patients.
And allow me to clarify. For me, incentives don't necessarily equate to monetary.
Oh, Celine, I think you ended up on mute. I don't know if you ended just wanting to incentives not equating to monetary. I feel
Yeah,
like you were saying more.
Oh, no. Maybe it was deflection in my voice, and I apologize. I can't share my video.
No problem.
Yeah, so I just wanted to clarify that to me, monetary does not equate, or incentives does not equate to monetary. That's all. Because there can be incentives that are not monetarily driven, if you will.
That makes sense. Do you have any ideas for examples of what would be helpful there? And then Brian, I see your hand raised after Sue Ellen.
Chelsea, you put me on the spot. I don't. Oh my gosh. Any other day I would have one.
You can think about it. Sorry, I put you on the spot.
That's okay. I'll think about it. I was just about to say, I'll think about it and I'll give you one.
Okay, Brian.
Just from a from an EHR's perspective, historically incentives have focused on the customers who purchase EHR. So I think it's important to look at the lessons we've learned from meaningful use, for example. And what we drove with meaningful use was a very transactional view of healthcare, right? Individual transactions between a provider and a patient without really an eye toward and maybe that was the critical first step to get everyone at least doing those initial transactions digital. But I think as we look at incentives now, we can still focus on the consumer, which is the healthcare provider purchasing technology, but we can create incentives for purchasing technology where the communication collaboration capabilities are not ancillary or satellite or add-on. They are part of that. Now, on the flip side, we can also do things from a regulation perspective for health IT vendors that prohibit information blocking and make interoperability much more critical. That's more the stick than the carrot. But I do think from an incentive perspective, it's not all about money, but if you follow the money and look at purchasing decisions, vendors will follow that, and if you drive incentives, there's a lot of unintended consequences. So I just wanted to share that. I think there's a lot of really important lessons learned from meaningful use and sort of what we came out of it with. There's a debate about how successful it was. I think there are a lot of people not on paper, which is great. That sets the table for more, which is what we're talking about. But it also, I think, failed to probably move as quickly as we needed to from a transactional model to a collaborative model. And I'm probably preaching to the choir on that, but I do think there is room to really think hard about meaningful use like incentives, but where the meaning of the use is around collaboration and multiple entities versus meaningful use being very focused on individual transaction. So I'll just leave it there, but I think there's a significant opportunity.
Thank you for that, Brian. And Jerry shared some potential non-monetary incentives of less burden, quality of life, convenience, and PJ time. Is like pajama time, Jerry, or okay? I like that. And then thank you, Kim, for sharing the resource about the physician staff hours. Mike?
Yeah, I think, I mean, so what it's coming to me in thinking about this is really incentive is difficult or a requirement, but when you think about programs like patient-centered medical home, they have certain requirements to qualify, and then insurers or payers will sometimes pay a per member per month fee. And so this would work well into that framework where certain functionality needs to be part of the practice in order to qualify for perhaps a higher tier of benefits.
And there was also a message from Kim in the chat, I think in response to Brian, but correct me if I'm wrong. Why does the physician have to purchase that? Shouldn't interoperability be standard to allow better care of patients? I think that's a...
I mean,
I don't know if that's directed to you, Brian, but just a...
No, I can give a thought on that. I mean, I think we have to be careful not to vilify technology vendors or insurance companies. Like, I think ultimately we all have shared goals. I don't think physicians should have to buy interoperability at all, but I do think it is fair to have to buy software because software developers don't work for free, which I'm painfully aware of. And we compete as a software vendor with people like Apple and other companies, which it's tricky to get really talented, innovative people driving healthcare technology. So I totally agree with the comment that we shouldn't have to buy. We should like interoperability, but interoperability is becoming the standard. Like information, there's legislation that prohibits information blocking and makes data accessible, and you will be irrelevant as a vendor if you don't support that. However, I do think, there still is a marketplace for buying technology and providing incentives to the buyers who are making purchase decisions to buy technology that moves healthcare where we want it to go versus buying technology that does things in a different way. It will get us there faster. So I hope that makes sense. Not all vendors are bad, and not all insurance companies are bad either. I think if we just focus on the shared goals of outcomes and quality and putting the patient at the center. I mean, the triple aim is not it's there for a reason, and I think it helps align us across different stakeholders. So I hope that makes sense. I hope my comment wasn't taken as, people should have to buy this stuff. That certainly wasn't the intent.
And Brian, to add to what you're saying, if we, like you said, the patient is the center. And so our focus needs to be on those care coordination activities. And it's what's in the best interest of the patient and their caregivers. And we make those recommendations based on that. And then we say, this is the recommendations, holistically speaking, on how we can achieve that. And then then we have to turn it over, because if we try to do too much with this, then we're going to get overwhelmed and we'll lose direction. And so will those who are reading those recommendations. So I think just keeping our focus on the patient and doing what's in the best interest to achieve that care coordination will hopefully get us to a better place.
Thank you both. Rich?
Yeah, I actually want to compliment the exchange there with Kim and then Brian and then Svel, and that was well done. And I'm almost done putting this in chat, but I'll say it, but I want the staff to see this. So Brian, I think your point is really well taken. There's no space here to vilify. Truly, I think our committee is making the point that we're all in this together. Patients, families, caregivers are in the middle. We have to work about this. The way I'm thinking about it, though, is depending on how those additional technology resources are allocated and monetized, I think the way I interpreted Kim's question is, who would pay for that? And I just want to make sure that whoever's paying for that last mile of technology is not necessarily the person doing the care delivery, especially, and this is the total framing for this is in the equity space, especially for those clinicians that probably are serving under-resourced communities to begin with. And so that's something that Michael had alluded to about, well, could this be linked to could you get an enhanced reimbursement if you are mitigating disparities in your outcomes? If you're, showing improvement, et cetera. So there's a complex series of factors that have to call out. But the way I want to sort of reflect on Kim's comment is, yeah, we don't want to put the folks that are already serving in under-resourced communities in a position where they can't meet these parameters. But we all have to do this work together.
I just want to say I'm glad you said I've been in some conversations very recently where we talk about not putting the burden of that last mile of communication on the healthcare provider, particularly those caring for vulnerable populations. What that typically circles back to is payers often have a vested interest here, whomever the payer is. And that gets back to the first question that we were asking, like how much access should we give them? And how do we look at payers as stakeholders? It's difficult because payers perform different functions, but as someone astutely observed, many payers have lots of programs focused on driving better outcomes, and they have an incentive to keep costs down, which can correlate highly with better outcomes patient by patient. Now, sometimes that also creates some other conflicts of interest in restriction of care and other things like that. But I thought that is very interesting that we sort of come back to that first question sometimes when we think about who pays for that last mile.
And if we don't keep that at top of mind, then we're not being collectively showing a collective fidelity to the goal of it's about the patient, the family, and the caregiver unit. And for me, that's the North Star. And I think that'll kind of get at where Kim is aiming for. But thank you for sharing that experience. And I think, Chelsea, to you and the NQF team, thank you for allowing this conversation to proceed, because this is really moving our recommendations toward implementation. And thank you for giving us the ability to unpack this. Clearly, the stakeholders have to have their issues, vulnerabilities addressed to do this collectively.
Great. Yeah, I agree. It's always just easy to say like, yeah, we need incentives, but I think this conversation has been really helpful. And so we'll certainly flesh that out a little bit more in the reports. Any other final thoughts or recommendation or comments about this question? And certainly with any of the questions, if you think of something afterwards, please feel free to share them with NCAP staff, and we'll make sure that gets incorporated. But I think we can go ahead and move on to the next question. Excuse me. Can we go to the next slide, Evelyn, please? In the interest of time, I will start talking through that. So this question that you'll see on the next slide is related to the incentives that are shared, that were shared by the public commenters. So additional context, the CDC's adapting clinical guidelines for the digital age, which is an integrated process to develop and implement narrative and computable guidance using FHIR to improve how clinical guidance is used in practice and how it can be disseminated through clinical decision support systems. And the other is ONC's Trusted Exchange Framework and Common Agreement, which establishes a universal floor for interoperability nationwide by creating the infrastructure model and governing approach for users in different networks to share basic clinical information. So both of these were new incentives to us. I don't think our colleagues from ONC were able to join, but if anybody has any familiarity with these incentives or any additional information to add, or if it seems reasonable to like go ahead and add it, certainly understanding this would just be kind of more mentioning, not doing a deep dive like some of the other incentives that we've looked at. So any thoughts there?
Sorry, is this incentives or initiatives?
Oh, initiatives. I might have carried over our last conversation.
Yeah,
So
I
I'm
was gonna
sorry.
say,
They are,
you had incentive
they are
on the
initiatives.
mind.
Yeah. Yes, you do. They're definitely on my mind.
Got it.
Sorry about that. Thank you for clarifying. Yes. So initiatives, not incentives. As far as I know, anyway.
Yeah. Well, honestly, I mean, these are great suggestions. And I think that, well, I hate to assume that's not a good thing to do. I mean, I'm thinking out loud, so I apologize because I'm trying to think it through. I would think that this would happen, but I guess again, we shouldn't make assumptions, so having it in there would be prudent. And I think both of these are great suggestions.
Thank you, Sue Ellen. So I have Jerry, then Alexis, then Brian. So let's start with you, Jerry.
I agree with Sue Ellen. I think they should be mentioned. And in the spirit of what Rich started his comments at the very beginning, that this is the beginning and that we want to see these recommendations used and go into practice, this also gives us ideas about who to share the reports with. And so I would also include it in not only as examples of, work that's going on simultaneously, but next steps. Who are the key groups that are doing work in this area that we need to share what our recommendations are? So I would use it in both of those options.
Thank you, Jerry. Alexis, then Brian.
Yeah, I would agree. I would say that we could make a recommendation within the report that says something simply like, initiatives should align with, or the recommendation would be to align with initiatives that are already out there from ONC and any other identified, organization that we come up with. I don't see a reason why we couldn't include it. I think that work is inevitably going to get pushed forward. So making a recommendation that we align with it makes sense.
And Brian.
I think consideration on the first topic, clinical guidelines have often been very disease focused, and people are more complex than a specific disease. So as we adapt, like some of that limitation was simply because technology was not capable of creating a wide enough view of context for a whole person and all the variables surrounding them. And I think as we adapt clinical guidelines, it's important to try to break free of some of that and truly harness technology. So we're not just looking at best practice guidance for someone with diabetes, but we understand that diabetes in conjunction with heart disease, in conjunction with an amputation, in conjunction with have a very specific pathway or guideline that can be almost customized to the person. And so just staying person-centric and not being too tied to some of the historical paradigms that were very disease-focused, I think is important for adapting clinical guidelines. I'm super excited about what technology will allow us to do here and open that up. I think on the TEFCA front, I think TEFCA will be a game changer, but we have to be careful. And this was, I think, echoing the comment just previously. We have to be careful that we don't set a bar that doesn't acknowledge some of the progress we've made or obsolete some of the things we've already done. And so a lot of the HIEs and other frameworks which have sort of moved us in a direction around interoperability and coordination have done really good things, and we could easily sort of obsolete them. We have to figure out how they can be a stepping stone to the future without obsoleting them or slowing us down. So those are just two comments.
Thank you, Brian. And I see Katie and Kim with their hands raised, and also just want to point out Colleen's comment in the chat that CMS is currently soliciting comments for how to advance TEFCA as part of the 2023 physician fee schedule and quality payment program proposed rule. So Katie and then Kim.
Thanks, Chelsea. I am a measure developer, so I'm less in the clinical guideline space and more aware of some of the interoperability work going on. So I defer to other committee members or colleagues on this call who are more familiar with clinical guidelines. My comment is just more general to make sure that we haven't necessarily, as a committee, we did not dive into these types of things. So just before we start sticking particular initiatives or particular clinical guidelines into a report, unless, again, my colleagues are confident in this work by the CDC being prominent or best practice, or they're kind of at the lead of this work. It's just a general warning to be careful about what we stick in a report or not without fully kind of vetting the topic.
Thank you for that, Katie, and a good point. Kim?
I just I put the link to the FHIR document, and I really like figure 1.4, which if you look at it, it shows sort of the current state of how we do guidelines and all of this type of work, and thinking about how do we really tell practices and physicians and practices how to really do this if we were to come out with it. And I really like this consistent feedback loop that they have listed there, that be really important that we ensure that we have whatever the EQMs that develop from our work, that there is that consistent feedback loop. And I do think that looking at this document, although very briefly, I think it would be very good to have in our document.
Thank you, Kim. Any other final thoughts about either of these? So it looks like looking into them just a little bit more, but as long as it does make sense, including it or referencing them at least in the report seems, again, making sure that it does align. All right, Mike?
I would just agree with Katie. I think that, the second one, TEFCA, seems like we should mention it, obviously for care coordination, establishing, interoperability is very important. For the adapting clinical guidelines, I think, I think it's kind of out of scope. I mean, I think that it's a good idea, but I would avoid, I don't see quite how it's kind of like a core part of what we've been asked to do as part of this committee.
Thank you for that, Mike. Great. I think we can go on to the next set of questions. Was really just kind of a catch-all if there were any public comments that stood out to any of the committee members that you wanted to make sure that we raised here. Some of them we think we can just very easily kind of incorporate maybe some additional details or additional examples. Or if you had a chance to look at the draft proposed responses and had any thoughts there. But again, a lot of those we wanted to wait until we had this discussion first before we drafted those actual responses. So I'll just leave it here if there's anything else from the public comment side that we want to cover. Okay, so I think we can go ahead and transition to, I think, another really nice set of discussion questions. So on the next slide, we will transition to the themes from the feedback we received from the committee. We had 6 members who provided feedback on these versions of the reports, not including feedback that we've received from previous versions. The feedback included needing to highlight the opportunity and urgency for improving care communication and care coordination more explicitly, as well as presenting the recommendations in both reports consistently. It was also recommended to clarify the differences between the second and third recommendations in the shortened report, as they seemed redundant with how they're currently presented. And there were also recommendations to strengthen the language around the importance of patient trust as a barrier in shared decision-making. Before we get into more specific discussion questions, I did want to just open it up to ask the committee for their overall reactions to the reports, or if there's any general feedback you may have on them, particularly if you didn't have an opportunity to share anything via email. So really just trying to, see if they're resonating or if they, are capturing our recommendations appropriately. Again, we'll get into more details, but just wanted to leave some space for some overall reactions. I'm hoping silence means that they align with what we've been working on, and they're on the right track, and not the opposite.
Yeah, I think they're on the right track. And so are these themes to just make sure that these are things that we do or that we have not done and they want us to consider?
So these were just kind of, we wanted to highlight what we talked about. We'll get into like additional discussion questions. I think, things like highlighting the opportunity for urgency, the opportunity and the urgency, like we can incorporate that. There are a couple of additional questions about like definitions and how the recommendations are framed, but just wanted to give the opportunity if there's, if there were any overall reactions to the reports.
Okay.
Yeah.
All right. Thank
So
you.
yeah, we'll get into more detail there.
Okay. That makes sense. Thank you.
Not hearing any kind of overarching, I think we'll go ahead and get into the more detailed questions that might help brainstorm some other ideas there. Excuse me. So because the audience of the shortened report is less technical, we use simplified definitions for care communication and care coordination, noting that care coordination denotes the organizing patient care activities and information to meet patient family needs and preferences for healthcare and related services. And care communication is the transfer of information for care, which is a critical component of care coordination. So we just wanted to see if these simplified definitions adequately represented care communication and care coordination, or the longer versions, which I can share if nobody remembers those, but those are in the long report and what we worked on last year. So the longer definition for care coordination was the deliberate synchronization of activities and information to improve health outcomes to ensure patient and family needs and preferences for healthcare and community services are met over the course of their treatment and care. Care communication is the transfer of information related to patient care. So, you know, curious if anybody has thoughts on that. And I see I was Brett, did you have your hand raised? I don't actually see that. Okay, but Jerry, I do see your hand raised.
Okay, these are things that I had shared in my written comments. I'm good with the shortened version of care coordination. It comes close enough and it has most of the important pieces. My recommendation on care communication is to have a more active word than transfer. Transfer seems very passive to me. And I would suggest a word like exchange or something that folks can come up with that's more active, but we don't just transfer information. There is a dialogue that happens in care coordination and communication. I'm not just giving the information to another person. There's more behind it than that.
Thank you, Jerry. Alexa.
Yeah, I would say that the shortened version of both really don't capture, you know, care coordination or care communication enough for someone reading this shortened final recommendations report to understand what we're talking about. And I would suggest just leaving the longer definitions. We're shortening the report, but I don't see the need to shorten the actual definition for either.
Thank you for that perspective, Alexis. Any other kind of thoughts or a strong feeling either way? I appreciate that, Alexis.
I agree with what Jerry said about having that dialogue exchange and dialogue. I don't know if it has to be verbal when you're talking dialogue, you know, and I know some people really focus in on, you know, things like that. So you may need to be cognizant of that. But I agree, there needs to be a more, a better word than what we have.
Okay, so it sounds like it might be okay to keep the shorter definitions with just modifying care communication, but also maybe look at, do we really need to do that, to Alexis's point? We can revisit that. Yeah, I understand. Thank you for that, Alexis. We did spend a lot of time talking about it. I agree. Okay. Any other final thoughts there? Okay, so I think we can go to the next slide. So there are a couple questions around this. So right now in the shortened report, the recommendations are in three categories, or like there are three recommendations. So one is to optimize EHR functionalities for care communication and care coordination. The second is advance EHR data elements related to care communication and care coordination. And recommendation 3 is to leverage EHR data to fill care communication and care coordination measurement gaps. Excuse me. So the first question, so while the recommendations are the same in both, they are presented differently. In the long report, there's essentially 2 recommendations that have 3 themes underneath them. in the short report, we kind of simplified that to just have 3 recommendations. So I think wanting to start first with, should the recommendation categories be presented consistently in both reports? Or any strong feelings to like not have that or to have that?
Definitely think that you should have it presented consistently in both reports.
That is understandable. I will say it was intentional to have them not be the same because of the different audiences, but that makes sense. If we have another agree with consistency, always optimal. Okay, so I think we will do that. So I don't think we need to debate that much more. So the next piece is, do the titles of the categories effectively portray the intent of the recommendation? So for context, we did get a recommendation of another way to clarify these. So if we could go to the next slide. So, and again, these are just, potential category that we can use, and certainly open to different ideas, particularly if there's anything you want to shorten it. But so instead of optimize EHR functionalities for care communication and care coordination, it would be optimize EHR functionalities necessary to improve care communication and care coordination. The next one would be expand the set of EHR data elements available to measure core care communication and care communication processes and outcomes, and then leverage the potential of EHR source data to fill high priority care communication and care coordination measurement gaps by developing new EHR source measures and improving current measures. So these are what we're trying to identify, like what the recommendations are, but curious if there are thoughts for, a little bit more simple on the left, getting into that further detail on the right, if there's other ways that people think could be helpful to capture that level of detail, because I do think we want to make sure if someone's, potentially, for example, only reading the executive summary, they understand what the recommendations are. And Cindy, I see your hand raised.
Yeah, as I was reviewing the recommendations, I always like to have, when I think about structuring something that you want to catch people's attention, what's 1 or 2 words that we can use that kind of sets people up for the recommendation. And when I look at them, and I think this helps address this other question on how do we distinguish between recommendations 2 and 3. The first recommendation is related to the technological infrastructure. So do we have the technology in place that can enable the functionality that we want, the interoperability and all that? So technological infrastructure, blah, blah, blah. The second has to do with the data infrastructure, or the data, the approach to data, the data modeling, or something like that. So it's defining the data. So data something or other, boom, expand the data elements. Once we have both of those in place, then we can use them. So it's technology infrastructure, data infrastructure, use of those, and applying that. So that's how I see the difference between 2 and 3. 2 is setting up the data infrastructure. 3 is actually using the data and using what we've got.
That's really helpful, Cindy, and certainly how I've been kind of thinking about that, but not in those words. Alexis?
Yeah, I would agree with what Cynthia was just saying about the differences and how we differentiate 2 and 3. Furthermore, I would say that the potentially updated recommendation in the first column, I really like that one because I like how it talks about that it's necessary for improving the care coordination and care communication, not just like it's just a function. So I really like that expanded one. The second one confuses me a little bit because on the left, we say advance EHR data elements related to it. But then on the right, we're saying expand the set of data elements. So are we advancing, like coming up, recommending that we need to come up with new replacements, new additions, or are we expanding the set based on things that are already out there? So I think that there needs to be some more clarification if you want to expand it and change the way that it's written on the right. Doesn't really align with advancing. The last one I would just say is it's great. Like it's always better to explain more, but it gets a little wordy. The last one's really hard to take in. And then for anyone on the outside of this work to really differentiate what we're talking about between 2 and 3. So I don't see a problem with leaving it with the way the one is on the left, or at least taking out some of the wordiness on the potentially updated one.
Thank you for that, Alexa. And I see from Sue Ellen modifying it a little to leverage EHR data sources to enable the ability to address those care gaps.
I combined a couple of those to address the data elements as well as that, then the leveraging of the EHR.
Kind of combining it like what Cindy was kind of mentioning, thinking of it that way as meeting those two needs. That's helpful.
Yeah.
Any other thoughts? Certainly seems like we'll align and it getting a little bit more detail, but maybe having kind of a keyword or two to introduce that to pull it all together. Any other thoughts?
I just have a question, I guess. I'm curious about the addition of the words high priority care communication. Like, are we setting ourselves up for someone having to figure out, well, what is high priority care communication? And how do we determine that? Like, who would determine whether it's high priority or not? So,
that's our next discussion question, Kim.
oh, okay. I did look ahead in the slides.
Nope, that's okay. Nope, that's okay.
Yeah,
Great.
that was just my only concern with the last one on the right-hand side, and just that it is super wordy and just, I'm just looking at the reading levels of these and thinking, oh boy, they're above 6th grade level, that's for sure.
That's really helpful, and we'll certainly keep that in mind, especially for the making, because we are trying to align it with both reports, making sure it is understandable for both.
Chelsea, this is Rich. Before we move on, you may have said this, and there was a click in the line, but in the second one, measure core care coordination. I'm stuck on the word core because it suggests that there is a core set of processes and outcomes. And while I dream about that and have for the last 20 years dreamt about it, I think it's still in unicorn territory. So is core a typo, or because otherwise I feel really uncomfortable using the word core processes loosely without specification.
Without identifying.
I'm sorry, could you repeat? I couldn't hear.
No, I feel like someone might have been talking and I was talking over them. Did I interrupt somebody? Okay. No, I think we can. It was an idea, but I to your point, I think we could easily remove that. And everything has been pretty. And we certainly don't want it to get confused with core elements either. Excuse me. Okay, perfect. So I think we can go ahead and go on to the next discussion question on the next slide. So based on our previous discussions, and I know the word priority might get a little sticky here, but we did, based on our discussions, present in the shortened final recommendation report. It's in the long report as well, but easier to identify in the shortened report. Top priority areas for advancing the use of EHR data for quality measurement. So those were develop an EHR sourced measure that identifies specific patient-oriented goals and whether being achieved, developed an EHR-based social determinants of health measure, and improve the specificity of existing measures related to downstream care after an index visit. So again, I know priority gets a little sticky, but really just trying to think of, are these the right things that we do want to highlight, but also understanding, sorry, my computer is doing something weird, but wondering if these are the priorities that would actually help advance care coordination, kind of thinking of those next steps. And yes, we will be consistent between. They are presented, it's just not as clearly presented in the short report, in the long report. Jerry.
Understanding that, we could all debate about priorities, and thinking back to our conversations over the last 2 years, and certainly patient-oriented goals and trust and equity and social determinants really rise high to the list. So if, in my view, we're going to just kind of limit the set of priority areas, and then I would say this reflects a lot of our discussion over the last many moons. We also talked about not getting so stuck on outcome measures that we forget that there are complex processes involved in care coordination that we're not tapping into. So, I guess I'm conflicted. On the one hand, patient-oriented goals, social determinants, equity. If I have to say, put a stake in the ground, yes, those are priorities. I don't want to forget the other areas that we need to, in the words of the previous discussion, advance care coordination and care communication measurement, and our process measures are not where they need to be. So I'd just be really interested to see where others weigh in on that.
I think a lot of the sort of quality work that practices do usually revolves around what benchmarks and what things they have to fix. For example, hypertension, because we know that that reduces morbidity, right? When you look at this sort of patient-oriented goal and whether they're being achieved, it may be something that may be totally pie in the sky that is not ever going to be able to be achieved, right? And so I just from just a very practical point of view, I just don't know how we're going to do number one. I think it's great. I just don't. I can see a lot of doctors going, oh great, another thing that is going to be patient oriented, which is wonderful, but how are we going to show that we've actually improved whatever it might be, and whether they've achieved it? And is it more busy work, or is it truly improving the quality of the care that we're providing for the patient?
Kim, this is Rich. Can you say a little bit more? Because I'm processing what you said and really want to try to capture the spirit of it there. And because I'm actually zealous about not adding busy work, but say a little bit more so I can get a better idea about how to move forward with the wording, please.
Sure. I mean, I'm just looking at, just if I were a doc that was reading that I have to now try and figure out a patient's specific patient oriented goal and whether that's being met, that would add a layer of complexity to my already busy having to fix their diabetes, hypertension, depression, and all of that. I mean, it may be something very simple. I think that it has to be very clear how it's presented and how you could achieve that measure, not in a difficult way. Like the patient couldn't decide, I want to lose 100 pounds when they may only be able to, that's not a reasonable goal. Does that make sense?
Yeah,
So,
it does. And that was actually why I wanted to give you a chance to say a bit more. So I've been in lots of conversations the last few years, the difference between the clinician saying to the patient or family, here's what the care goal is. And I used to, a few years ago, have to document that my 2-year-old patients, in fact, weren't smoking cigarettes because the system was expecting me to ask that question. But moving it to the realm of what are your priorities, and the recommendations for this technology transformation would be, how do we capture those goals? So I think that I want to differentiate your really important point about implementation of the the approach of care planning and goal definition and tracking from the ability of the EHR to do that. Because if you think about it, right now, if it's done at all, it's done quite manually, or it's done in a very perfunctory fashion. Does that add to your comment?
No, it helps a lot, Richard, and I appreciate your thoughts and helping me understand better how I would have to relay this back to a whole bunch of clinicians, that they won't be viewing that as an extra burden that they're not able to achieve, if that makes sense.
Yeah, I think so. So Chelsea, back to you and the staff, and I want to open up for others to comment on this. But this is a domain that I've spent a lot of time in. But I really think that what Kim is saying is, make it real. But this is not something that's currently being done, and then poof, the EHR is going to make it happen. So there is a developmental trajectory for clinicians and also patients, families, and caregivers to get into that space. But I'm so grateful, Kim, that you keep bringing this lens of practicality and real world experience. But I'd love to hear other people talk about it, because we could have a whole nother project on patient and family centered goal setting.
So we have Sue Ellen and then Brian.
So I think it's important that the onus of the success the patient doesn't fall or seem to fall on the provider, their primary care provider. The success of the patient belongs to the patient, their family, their primary care provider, and any other provider that is involved in the patient's care. And even though we do everything right, we get all their appointments set up, we make sure they have transportation, so on and so forth, that does not mean that the patient will be successful or that we'll be able to demonstrate through the data that the patient had a successful outcome. And so to Kim's point, having the onus fall on them and give, more burden, I think that's what we need to be careful of and keep in mind.
Thank you, Sue Ellen. Brian and then Alexis.
It strikes me that there's the difference between a patient-centered or patient-oriented goal and a patient-defined or patient-written goal. And I think sometimes we merge those two concepts, which gets us to the question of, is this goal practical or realistic? I think ultimately, as caregivers, we should orient around practical goals that are realistic and are person-centric or patient-oriented, but sometimes we're too quick to just pass the pen over or, precede a goal with someone's name, and neither of those things are that impactful. So I guess my question is, I think I read the spirit of patient-oriented differently than sort of saying, well, here, write your own goals, which may or may not be realistic, and we'll try to achieve them. And I think that is a frustrating thing, but I understand the sentiment behind it, right? Really wanting to align around a person and their wishes and desires. So it's a tricky thing for sure, but I'm curious what we mean, because what I don't necessarily mean patient written or read that when I see or hear patient oriented or patient centric. I just think it's more about the alignment than about the specific expression of that goal. Does that make sense? I just would be curious what other people would say.
Alexis?
Yeah, I mean, I just wanted to respond to Rebecca's comment in the chat about looking at other improvements because it's difficult to engage with patients, no matter how much we try. There's always going to be patients that are difficult to engage with. That doesn't mean that we shouldn't ask and have them participate in a shared decision-making process, and ask them about what their goals are and try to align them in a shared process. If they don't want to offer a goal and they don't have any, and you can't engage them in a way that gets them to bring out that goal, then that's fine. But for the people the patients and the families that would like those goals that they have identified as important to them and to their care, reflected in the EHR, and then be able to measure their care against that, we have to be asking and we have to include that. So it's okay if it's difficult to engage people and we don't get it 100% of the time, because we won't. But we're going to get it when we need it, and it needs to be there for the person who wants it there. And we've talked many, many meetings about how we measure this and, what the goal is. And I think that's just something that, needs to remain a priority. And then just to, sorry, I forget who was talking. I think, was it just Brian who was reflecting on the difference between patient-oriented and the two different goals? I would say my perspective is that, the examples are kind of in the longer report, maybe even in the shorter one, where, a patient-oriented goal may be something that a provider hasn't thought about at all. I think the example is in there, like, I want to dance at my daughter's wedding or walk my daughter down the aisle, something like that. Where, a provider goal, just off the top of my head, an example, maybe physical therapy has a goal written specifically because they need to get something covered by insurance, and a goal that can be measured, a very concrete goal of, this person's going to improve their 6-minute walk test by however many seconds or, minutes or yards. And it's about finding that common ground of that kind of goal setting versus what's most important to the patient. And then we can only measure the care that we're giving and that patients are receiving if we're actually measuring what the patient themselves is identifying as most important to their care.
Thank you, Alexis. Rebecca?
Thank you. So I appreciate that, Sue Ellen. But as someone who's, done this for, worked with as a case care manager, trying to engage patients, and also, training case managers on how to improve engagement, it really depends on the patient. And I think you have to be careful about asking somebody what their goals are rather than asking them what's important to them. And by asking them what's important to them, they usually engage better, and you can work on, specific measurable goals. But I think it's important. I mean, from a priority standpoint, I really think the second and third priorities here really need to be focused on before we actually use the EHR to set up specific patient-oriented goals. But I think it's important to do that. And my intent was not to indicate that I didn't think it was. But it's really, from that perspective of trying to engage patients, it's really more, you start with asking them what's important to them and then graduate to goals.
Thank you for that, Rebecca. And I think a little additional kind of context for how I was sort of thinking about the patient-specific oriented goals. And my apologies, because I can't remember if it was Katie or Cindy, or maybe not even during one of our conversations during our committee meeting. But I think there are some measures that are being created where, the range is the part that it's not like, did you meet it, yes or no, but maybe it's like an improvement of 1 to 2 points based on where you are to begin with. So I think, the goal could be whatever the patient-oriented goal is, but then the actual rating system, or did they meet it, like that part could be the consistent piece. So like that part is what could be measured. And so you could still have essentially like the free text for the goal, but then for the, getting it to the measurement piece, like the, like the ICD-10 code or whatever related to, not ICD-10, whatever, blank code. I still am confused by all of that stuff. we're just trying to think through different ways where you can have that patient-oriented goal, but it's still specific and it's still measurable. But it seems like we can kind of think about maybe the order. But certainly, to me, the patient-oriented goals and the patient-centeredness was really foundational to all of the things that we've talked about. But we certainly want to keep in mind the practicality as well. But any other final thoughts about these? Katie. Oh, Katie, then Jerry.
So mine is actually on the second bullet, so I wanted to wait to get through that first conversation, and it's not huge, but perhaps important, which is simply that we've done a lot of discussion of social determinants of health, and I feel like we've talked at least about two things. One, are they being considered in care coordination and care communication, and also are they being captured? And I just feel like this bullet falls a little bit short about what we're recommending. Are we recommending better capture? Are we recommending better availability for clinician use, or both? I'm just suggesting that this bullet be a little clearer about what kind of measure we are recommending or identifying as a priority.
That's helpful. Jerry?
Yeah, I really appreciate this discussion about patient-oriented goals. And what my takeaway is, it's not a question of looking at what's important to the patient. The phrasing of this is really important so that we communicate that, and I think we have done that in the report, that our view as a committee is that the patient is at the center of this, and I think Rich has given some really good examples of how to address patient-centeredness, going back, I think, to what Brian was saying. I think we need to massage the wording of this, Chelsea, that we don't lose patient-centeredness and throw the baby out with the bathwater. We just need to be realistic about how we phrase it so that we're not setting the bar so high and confusing the heck out of people. And I think Dorothy has given some nice language about it as well.
Thank you. Yeah, I'm capturing all of that in my notes. Any other final thoughts? All right, well, if you think of anything, and due to time, the next set of questions was just if there were any additional recommendations or anything else that anybody wanted to add. So if there is anything, please feel free to email myself or the NQF team, and we'll make sure to capture that. But I did want to go ahead and transition us to our next discussion since we're running a little behind. So Ellen, if you could skip forward. So we'll be talking about the future steps for this work. And before I turn it over to Rich and Jerry, I wanted to turn it over to our CMS core, Kim Rawlings, just to give a little bit of context about how this work fits into the rest of CMS's vision and goals. So Kim?
Thanks, excuse me. Thanks, Chelsea. Can you hear me okay?
Yes.
All right. So just want to say good afternoon, everyone. Thanks so much, Rich and Jerry, for inviting me to speak briefly. As stated, my name is Kim Rawlings, and I work kind of very far behind the scenes with the team to help guide this work. Though I have to admit, with great leadership from your co-chairs and all the enthusiasm and participation from you guys, sometimes I have very little to do because you guys are doing such an awesome job. So first, just want to say thank you for everything that you've done in developing these recommendations. I did just want to put this a little bit in context, though, when we discuss like further steps and just talk about, a little bit about what we're doing at CMS when it comes to care coordination, et cetera. So over the last couple months, we have been working a lot on refining the CMS National Quality Strategy goals. Those sets of goals kind of debuted at the CMS Quality Conference back in April. I won't review like all 8 of the goals. They're online. You can definitely Google them is probably the fastest way to get there. But I will say that there are two that I think really align with the work of this group. First, accelerating the digital transition, and two, embedding quality across the care journey. And we've heard so much from Joel and Kyle around the commitment from CMS and ONC to really transition to digital measurement. And just wanted to really reiterate that that is a key pillar of the CMS National Quality Strategy. And we're really working towards accelerating that transition to digital data on multiple fronts, from the data standardization from UCDI, et cetera, that you guys have been talking a lot about, or implementing the FHIR AIP. Those are the building blocks that we are definitely committing to, that I think really, are foundational to achieving a lot of the recommendations in the report that you guys have developed over the last year. Additionally, we do have another quality strategy goal around embedding quality across the care journey. And I really love those words, because you can't talk about care journey without talking about care coordination. And so by embedding quality across care journey, I feel like we're really embedding a commitment to care coordination, to seamless care coordination. And we can't think about, whether it be whole person care, seamless coordinated services, person-centered care, all of those have this foundation, have care coordination kind of at the forefront when we're talking about all of those topics. And those are really some of the key thoughts, the key foundational items in the National Quality Strategy. And so I not only wanted to thank you for your commitment and your enthusiasm around the topic, but definitely say that we here at CMS share that enthusiasm too. And I think that a lot of the recommendations that you guys have come up with really dovetail nicely with our national quality strategy. And so looking forward to having the final report in our hands and integrating it into all of the steps that we're taking in the future. Thanks, Chelsea.
Thank you so much, Kim. And I'll turn it over to Rich and Jerry, and we go to the next slide with the discussion questions, but also kind of an open discussion as well.
Thanks, Chelsea, and Kim, thank you for your remarks. So for our committee, this wonderful statement from CMS about how this aligns nicely with the strategy going forward. And so this section of today's meeting is not about our committee or this group. So it really has everything to do with this project is now over. The work product will be in the field. Now what? And I really hope that people will weigh in. We want you to use the lens of your own voice, the organization that you work for, an entity that you may be dedicated to because you or your organization are a stakeholder to assuring equitable outcomes there. So this is really a discussion about, now we've got a report in hand, and as I've sort of reminded myself, this is just the beginning. It might be the end of 2 years of work, but it's the beginning of now what are we going to do about it. So I'd like to be able to open this up. And in fact, Kim's put something in the chat. Kim, would you mind maybe making the first opening statement, please?
Sure. I think that, the final recommendations are wonderful. And however, if we don't actually get this out to everyone, we're not going to be able to really get feedback on all the final recommendations, and point in case that we didn't really get too many comments on previous iterations of the report. So it would be wonderful if we make sure that we send this to all the different medical societies and different organizations and stakeholders to ensure that we get adequate feedback and response from them.
And would you frame it? I'm going to just stick with you one more time, and then I want to continue the circle here. But how would you frame this, Kim, in a way so that the message is sticky for them? Because we'd like it not just to be, okay, here's another NQF report, but maybe make a suggestion how we can make it sticky for those audiences.
Well, there's ways in which you can send it to specific departments rather than just to the organization period if you wanted to get actual feedback from that, which would require a little bit more investigation on our part to know that we're sending it to the right departments to get feedback. Maybe we actually have an ask and say, would your board or would your department of whatever EHR, whatever care coordination, if you have such a department, would they be willing to actually give a few statements about it? Maybe it means that we ask for a meeting with certain individual organizations just to get actual feedback verbally or in written format, so to make it more of an ask rather than information.
I really like that a lot, and especially if the ask is, and this can help you with a pain point. Others, in fact, Jerry, I want to make sure that I'm inviting you into this as well, both to moderate as well as to make statements. But who else would like to weigh in about next steps?
I was thinking, Rich, Dave has a comment in chat. Dave, would you talk about that a little bit?
Sure. I mean, basically just thinking, if we want to get the word out there, there's different conferences that, health plan provider groups that, attend. Maybe, we have representatives at those conferences that could, present in a session and go through this, and maybe even have a table or something, where folks can come up or have a conversation during the break, whether it's an AMA conference or a RISE, conference, whether it's STARS related or value-based or, any of those kind of things. But, just to be able to get out there where there's a meaningful number of folks that, are looking for information on this kind of stuff and anything else.
Thanks, Dave. I agree, and especially CMS and the ONC have been critical collaborators in this work with us, and so we can in those discussions could even demonstrate how there's intentional alignment.
Right. Yeah, absolutely.
Alexis and Dorothy, I always appreciate when our family partners weigh in. So you put something in the chat, Alexis, but if you could unpack that, and if Dorothy, if you're able to make a statement, that would be great as well.
I'll go after Alexis goes.
Alexis?
Sorry, my computer was not unmuting. Yeah, I mean, I didn't put anything too earth-shattering in the chat. I was just saying that everybody in the committee should make an effort to spread the dissemination of the reports via the, all the work groups and such that they're affiliated with, and whatever social media channels they use in their daily work. And then NQF should think about disseminating the reports to groups like IHI and others who could potentially put a link to the reports in a newsletter or their email update blasts, that kind of thing.
Dorothy.
This is Dorothy. I would agree with that aspect of getting the information out. But I guess I would also ask this committee or this team, will you do a follow-up? In other words, would you do some type of evaluation just to know who you have sent this information to and whether or not there will be a feedback as to the number you send it out to, and also those persons that may have had an opportunity to read through it, and if they had questions, and whether or not you will get back to this committee, those persons on this committee, to say, hey, look, we sent it out to 150% took a look at it. Because personally, I would be interested in knowing. And the reason I say that is, I'm on a lot of calls and information is shared, but the persons that are participating never get any feedback on where does the report goes? What percentage of individual at least received it or provided feedback? So that would be my response to that. Thank you.
Thank you, Dorothy. Others, either in chat or verbally?
Rich, like the others, I'm thinking about the groups that I'm a member of and how I can not only get the word out, but kind of like what you and Kim were talking about, is how to encourage movement into action. And just to give a couple of examples, so in my space, I co-chair other NQF committees that are relevant to care coordination and care communication. And I'm thinking this should be back of mind in the work we're doing when we talk about gaps and how we can align with this. And the other is in my professional space as a nurse. The American Academy of Nursing has been very active in looking at care coordination and moving it forward. And I'm thinking to myself, kind of like Kim, what you were saying, who can I send this to? What can I encourage? And maybe a la what Dorothy was saying is not expecting people to take the whole report, but maybe identifying some key areas that our different organizations can really, be involved in because it's important.
And with this slight pause in conversation, I'll take this opportunity to share that before the end of September, I cannot tell you when yet, but before the end of September, we will be sending everybody like a publicity kit that is created by NQF based off of a press release that will be sent out. And then it'll be something that you can use to help create public social media posts or anything else you want to do from there. So we'll help give you the tools to help disseminate this. And then we'll certainly do that from our side as well. And if people have ideas of different organizations that, would make sense to hear from NQF specifically versus like all of you as colleagues. So if there are organizations where you think that would be helpful, we're trying to work on a publicity kit for people not on the committee as well, just to try to get that information out. And then I'll have to I really like Dorothy's idea of trying to quantify some of that. So I'll try to see what those options are.
Thanks, Chelsea. Brian, it's funny, I was thinking about your name just as your name appeared in the chat, and you've been, for the whole duration of this committee, you've been an incredible contributor. And I'm especially mindful of the viewpoint that you offered even just an hour or so ago. So can you speak a little bit to what you just shared in chat? Because this is a stakeholder group that is critical. And in fact, I'm going to argue because we don't necessarily have plug and play technology. How do we get this report in their hands so that they're meaningfully thinking about moving in that direction? So can you unmute Brian and share some of your wisdom, please?
Sure, such as much as it is, but I do think there's an interesting discipline at the intersection of technology, information, and healthcare, and that is informatics or healthcare informatics. And I was beginning to think of the American Nursing Informatics Association, organizations like HIMSS. These are places where vendors, go, but also healthcare providers. And and I would say even within a vendor, we probably can do a better job of connecting with, these types of societies that are, again, focused on making healthcare better by, pursuing this intersection of healthcare technology and business, if you will. So I do think there's certainly some opportunity there. I'll brainstorm a little bit about that. I know in our organization, which is Point Click Care, which is sort of expanded from EHR into care coordination more broadly with a couple of large acquisitions of Collective Medical and Audacious Inquiry. We now have a broad government affairs group, which also has essentially tentacles into state associations, again, that are all sort of informatics related, whether that's state vaccine registries or other things. So I will brainstorm on that and try to get back to you with some additional ideas. But sometimes we forget there is a whole discipline with, masters and PhDs in informatics and information technology that I think we could leverage. And they live at we live at the intersection between some of the technology vendors and some of the providers and more academic viewpoints. So I think I'll certainly do some more thinking about that.
Thank you so much. And we don't have, at least I don't think we have our social work colleagues with us today, unless he circled back after the roll call. So I really want to call that out. We've made a very intentional effort to move beyond the traditional only billable providers get to use the EMR, and I chose those words very carefully and very intentionally, right? We really wanted to move toward an EHR with connection to the patient, family, caregiver, but then also those other folks that are saying, I need to be able to add data if we're talking about care coordination. So I just, if somebody else could speak to that, that would be great. But otherwise, Chelsea and the NQF staff, if we could be sure to include on this list of other entities, let's make sure that organizations like social work, community health workers, behavioral health clinicians, folks that think about housing and food security, et cetera, but that all the entities that are stakeholders for optimizing equitable human health outcomes are at least aware of this, because I am very proud that we put content in our recommendations to make that tent bigger. And I think we probably have time for one more comment before I hand it back to Chelsea. Does anybody like to add one other element about next steps? So we're getting a great list in chat, Chelsea. Let me go ahead and hand that back to you now. And thanks, everybody. What's next is really important. Please, let's not sit on the laurels of this report. Let's get it out there. Let's push it. Let's advocate for changing the system.
Wonderful. Thank you both. So we'll go ahead and open up the opportunity for NQF and NQF member and public comment. And certainly noting all of the things in the chat, and also appreciate the HIMSS connection from one of our members of the public. So you can, and Don Casey, I see your hand raised. But if you're speaking, I cannot hear you. Oh, I'm sorry, Don, I can't hear you. Could we put the call-in information into the chat for Don in case there's a computer issue there? I see you unmuted, Don, but I can't hear you. Can someone from the NCAP team please send Don Casey the call-in information if you haven't yet? Okay, so Don, we will circle back. And certainly, as Rich said, feel free to put your comment in the chat as well. While we work on that technical issue, And it looks like there is a comment from Don. Accelerate the formal generation and evidence assessment of impact, effectiveness, safety, and risk of bias of care communication and care coordination, application programming interfaces across the entire digital health spectrum. These assessments should occur at both the individual patient and population levels and rely on formal, standard, and scientifically sound evaluation methods. These assessments should also include the ability to detect and monitor adverse and near-miss event rates related to both human and machine errors that most often occur through EHR and other digital health device usage. And notes he has a new computer that doesn't work, which I do understand that. And thank you for that comment. Any other comments? All right, hearing nothing else, I will turn it over to Udara for next steps.
Thank you so much, Chelsea. In terms of next steps, we would like to extend a huge heartfelt thank you for your contributions and dedication on the committee during both the base year and option year. We'd also like to ask you to please review your credentials and notify our project team of any updates that you may have by Friday, August 12th, in order to help ensure that everything is up to date for our reports. And both of the final recommendations reports will be posted on the project webpage on September 19th. As always, please feel free to contact our project team with any questions that you may have. And I'll now turn it over to Chelsea again for our final thank you.
Great. Thank you so much, Udara. And yet again, thank you all for your incredible engagement and dedication and support and contributions over the last 2 years. It's been an incredible 10 meetings that we've had over that time period. And I'm very proud of the work that we've done, and I hope all of you are as well. But I'll turn it over to Rich and Jerry, who are incredibly eloquent at expressing our gratitude. So not sure which one of you would like to get started, but I'll turn it over to you.
Go ahead, Jerry.
So Chelsea, you are eloquent, and you have been a fabulous, fabulous leader for this work. So thank you, everyone. It has been an incredible 2 years, and I would just acknowledge everybody's commitment